So next up, we've got this duo from New Jersey, Innovation Institute. How many people have heard of NJII, New Jersey Innovation Institute? Okay. All right, so we might start with a little intro of what that is, but they're the state designated HIE for New Jersey, and they're really doing a lot of great things. I've heard snippets here and there, but we're going to focus on their quality efforts today. And I just met these two, but they seem to be very professional and sharp and are doing a lot of interesting things. And we're so happy to have them here despite some flight issues and running around DTW airport and some canceled flights and so on. So we've had the CMS perspective, we've had the NCQA perspective, and we've had the Michigan Medicaid perspective. So let's hear from another state for what some of their experience has been in the quality space. So first we'll read these bios and then set them up for their presentation. So Annacler, Harris-Blevin is over here in the red, brings a wealth of experience in quality reporting for federal, state, and commercial value-based programs. She manages NJII's PQRS and MIPS registry for 6 years, overseeing CMS compliance and client support of over 10,000 clinicians nationwide. She now provides subject matter expertise to NJII's product development team as a product manager, helping to design the next generation of solutions to facilitate client success in value-based contracts. She's also pursuing her PhD in industrial engineering with a focus in value-based healthcare reimbursement models at NJIT. Sharlene Mock is a senior quality improvement advisor at NJII's Healthcare Delivery Systems iLab. She serves as a subject matter expert to all quality-related initiatives, including the federally funded Practice Transformation Network, PTN, which provides support and quality measurement services to over 9,000 clinicians. Over the past 5 years, Sharlene has also provided consulting and quality reporting services to hundreds of clients. She helps clients ranging from small independent physician practices to large multi-specialty health systems transition from fee-for-service to value-based care through continuous improvement. She earned her master's in healthcare systems management at the New Jersey Institute of Technology and is currently pursuing her MBA at NJIT as well. So please help me welcome Sharlene and Annacler.
Hi everyone. The weather here is definitely a lot better than Jersey. I don't have to wear a jacket, so I'm really happy about that. So thank you, Bo, for introducing myself and Annacler. We're really excited to be here today. Let's advance to the next slide. What we're going to cover today is an introduction of the New Jersey Innovation Institute as well as healthcare within New Jersey. So as you all know, every state does differ in terms of their advancement with technology in healthcare and also the different payer contracts and the relationships within the state. So we definitely want to dive a little bit deeper and give a different perspective from another state. We also would like to discuss the success in value-based care. So myself and Annacler have experience mostly within value-based reporting. And as Bo mentioned, we do help providers transition from fee-for-service into the value-based care landscape. So we'll be covering a little bit about our MIPS registry, the other solutions that we've built custom for our clients, the different types of payer contracts we work with, as well as our lessons learned in that realm of work that we do. And more importantly, I'm really excited to talk a little bit about the Practice Transformation Network, which is the primary program that I'm working on. It's a $50 million grant that was awarded from CMS. And we'll talk a little bit more about the details of it, but essentially it's a 4-year program to help providers from New Jersey, Maryland, and Puerto Rico achieve some type of transformation to reach value-based care and transition into an alternative payment model. Annacler is also going to discuss a custom solution that she's currently working on, which is our Measures Manager tool. And we'll talk about what's next for New Jersey Innovation Institute, what's next for New Jersey, and then answer any questions that our audience may have. Anything else you want to add? Okay. So a little bit about New Jersey Innovation Institute. So I'll start off actually with NJIT. NJIT is the New Jersey Institute of Technology. We're based out of Newark, New Jersey, and we are one of the polytechnic universities of the United States. And what NJII does is we are a non-for-profit organization that's a private entity of NJIT. And we work with NJIT's research departments to look into different regulations, what the healthcare problems are that we're facing, and then we use our technology that we build in-house to create custom solutions to resolve the problems for clients ranging from solo providers to large healthcare enterprise systems to even EHR vendors and different payers that we work with. So I'll give you a little bit of a history of NJII. We started back in 2010. We were actually known as the RAC Center for New Jersey, as the New Jersey High Tech, the Health Information Technology Extension Center. And back then, we had set a target of helping 5,000 providers achieve meaningful use, which I'm sure many of you are very knowledgeable about. And rather than just reaching the 5,000, we became the leading RAC of all of the states. We actually helped over 9,000 providers achieve their meaningful use objectives. So we were really able to establish ourselves within the healthcare industry by starting off in 2010. So we're fairly new, but we're definitely, as our executive director likes to say, we're no longer in this shop. We're no longer in the garage. We're really working on expanding our business, the work that we do, the solutions that we offer. In addition to becoming the Regional Extension Center, we were also HIE funded, and we supported 5 hospitals. That network was called the Highlander Health Data Network. Pretty soon after that, actually, the lady in red sitting next to me launched our first registry for CMS to handle the Physician Quality Reporting System program. So Annacler actually built our program from scratch. She started off as a team on her own. I actually became part of her team a year later, and we grew our team to, we have maybe like 15 people on our team now that actually work on the registry. So Annacler can talk a little bit more about her experience in that realm. But what we do with the PQRS reporting is we not only help with the consulting with the providers, but we also build a tool that the providers can use on their own or in conjunction with our actual advisors to look at their progress, select measures that pertain to their specialty, be compliant with their reporting, and more importantly, aim to achieve an incentive. And we also work with DSRIP, which is a program, a quality reporting program that's specific for hospitals within New Jersey. We worked with 17 hospitals, 5 different accountable care organizations. We've grown to now 7 accountable care organizations, and that covers almost over 500,000 lives. And in 2015, we did become the state-designated entity for health IT. So this part we are really, really excited about because there is a big problem within New Jersey, and that problem is that our providers do not have access to an all-payers claims database. So the providers are really blindsided when it comes to what they need to report and how they can actually use their data to work on performing better quality care and reducing their costs. And along in that year, 2015 was a great year, we got $50 million for that practice transformation grant that I spoke about a little bit earlier. And we'll talk a little bit more in detail, but that's a 4-year program. So we have the end of the program is going to be September 2019. Right now we have over 9,000 clinicians enrolled in our program from New Jersey, Maryland, and Puerto Rico. And so we are working with them to ensure that not only are they compliant with the MIPS reporting or any other reporting that they have to do, but that they're understanding that they have to transform the way that they're practicing in order to meet the goals and objectives of alternative payment models. We were also awarded the IAPD award in 2016, and we had an ongoing expansion for the Medicaid IAPD as well. And in 2018, this year, we are launching our first clinically integrated network, our SIN. So this is just a brief slide about our relationships with our biggest clients, and of course that covers the CMS, TCPI, which is the Transforming Clinical Practice Initiative. Those are the people who awarded us the $50 million. We are also working with the New Jersey Department of Health and Human Services, and United Healthcare, Horizon, and Aetna, which are the largest insurers in New Jersey. So just a little bit about New Jersey's healthcare. We have approximately 55% are employed under their employer, and still a pretty big population of 14% that are Medicare and 17% that are Medicaid. So you can see how it does really matter. Most of our providers do have a large population within the Medicare or the Medicaid network in which they need meaningful use assistance, MIPS reporting. In the past, it was PQRS. And now we're moving forward with helping our providers with their insurance, their payer contracts as well. And in 2015, New Jersey did have about, I think, 21 hospitals that were penalized for their admission rates, so not so great. We're a little bit better now. We are only at 15 of our hospitals that are penalized. We had 3 hospitals that were actually penalized every single year since the penalties were released. But as you can see, New Jersey is working towards a landscape where we are definitely working on improving the quality of care, getting access to data, and making sure that our providers are aware of direction that we need to move in. And something that's really exciting is that the Department of Health and Human Services are now starting to merge together. So the first merger is actually the transition of the Division of Mental Health and Addiction Services. So in 2017, that's when they began launching the merger of that. So we're hoping to see some really great results. We really think that once those 2 departments merge together, they can really focus on the quality of care for their patients and the reduction of costs in healthcare. So a little bit about the success of what we've learned within our 6 years as a registry. We've worked with providers who are solo providers all the way up into large healthcare systems comprised of multiple tax IDs, hundreds of providers. So we've really worked with a different variety of scenarios, I want to say. That stems off from the PQRS, which was the pay for reporting, the fee for service, and that transitioned into a pay for performance. So how well are you performing? And I'm not only gonna just issue you money now for every single visit that you bill me for, I wanna know that the visit that you gave was something that was contributing to the quality of care for the patient and something that the patient truly needed. So the government is going to start looking at, or they are already looking at, how value-based care is going to be the future of the payment models that they want to pursue. We're incorporating different cost measures as well. Quality has always been a very big thing that we've been talking about for many years. Cost is always talked about as well, but there's really not been very much transparency about how they're measuring the cost. So something that's been really interesting is that they did release, and they being CMS, did release a report that detailed the cost analysis of a single practice. So our organization was actually recognized by the TCPI group as being one of the leading PTNs in the nation that actually understood that report and was able to teach that report to our providers and what their cost measurement meant to them. We have the eligible clinicians that were in the PQRS program that are now transitioning into MIPS. Every year the MIPS program changes. I don't know if any of you have read the 2,000-something pages. I split it with my team. I was lucky I didn't have to read it all by myself. But I'm sure the doctors are all looking at this legislation and they're like, how am I supposed to understand any of this? And I've got so many patients to see a day. I've got to balance my checkbooks. I've got to make sure my staff is doing the right thing. And on top of all of this, I've got some lovely 2,000 pages to read after my dinner. So that's really something that our company helps the providers do, is we digest the information and we feed it back in a way that makes sense for them to ease their burden. We also work with different accountable care organizations. This aspect is really important for us because we want to be a well-rounded organization that has an idea of what we need to transition our providers into. So CMS is placing a lot of emphasis on the alternative payment model scheme, and ACO and MSSP, ACO being probably one of the most popular ones out there. So working with these ACOs in the past have really given us a good perspective on how to prepare our providers into becoming eligible for an ACO and attractive for an ACO to want the ACO to grab them into their network. And lastly, we've worked with 7 different multi-specialty hospitals and health systems. We work with clients actually throughout all of the United States, 45 states, including Alaska, Hawaii, and Puerto Rico at this point. So our 7 multi-specialty hospitals, we actually work with from Ohio, from California, Alaska. So we're getting a good perspective on the different states as well. And what I really want to highlight in this slide is that, Deloitte did do a survey in 2016 from all of the US physicians. They asked them, how do you feel about the program regulations? Do you think that you're able to handle them? What's your perspective on them? And I'm not really personally quite shocked about any of these results. 85% of the surveyed physicians said that they needed additional resources to comply with all of these Medicare regulations. 74% said that collecting and reporting information was really burdensome. And 20% of the physicians received data on the cost of care. So that's something that Annacler is going to highlight later in her part of the presentation, but the cost aspect is something that the providers are being measured on, but they have no idea on the methodology, the benchmarking, what they need to do to reduce their cost. All of that they're very blindsided by. And when you're thinking about more than 50% of their reimbursement is affected by something that they're so blindsided by, you really almost want to, you feel for the physicians. You want to help them achieve the best that they can, and you want to make sure that you give them all of the resources and the materials that they need to understand that. So that segues into my next slide. So let's define success. What is success in the eyes of a physician? First and foremost, it's the increased reimbursement, the ROI. They want to know that the work that they're putting in to do the reporting is going to be rewarded in some way, shape, or form. And that usually is within 2 years after they do the reporting. They get an increase on their Medicare incentive payment for their fee-for-service patients. In addition, they want to know that they're getting that high-quality rating. So some of you may know that these providers, when they report, they actually, their scores get published on a website called Physician Compare. So healthcare is very much moving into this type of industry where it's almost like Yelp. You can look up the score of your doctor before you want to go and see them. So now the doctors are nervous because their scores are getting published. Their patients are able to see whether or not they're a good doctor, a compliant doctor who has high quality rating. And they need to know that the work that they're doing is being reflected in that scorecard per se. And almost importantly, as the survey results did show us, they want to do this work effortlessly, seamlessly, painlessly. They want to make sure it doesn't disrupt their normal operations. They want to make sure that they're not spending more money doing the reporting and what they're actually earning. They want to make sure it makes sense for them. And when you have improved health outcomes, obviously that's something that the doctors are really focused on. They just want their patients to be well. They want their patients to be healthy, to live long. And when they're following these metrics and doing what these programs are telling them to do, they understand that this is actually for improving the health outcomes of their patient population. So because they're doing all of this work with us and with other organizations, they're getting that knowledge and they're able to understand how to prepare for the future. Because CMS is not going to back down, other payers are now hopping onto that same train. Quality and cost is really important, and these doctors, if they don't start keeping up with it, they're really going to fall behind the wheel. So let's talk a little bit about the barriers that the doctors face on a day-to-day basis. They want to be successful in quality reporting, but believe it or not, it's very hard for our team and other teams out there to engage these doctors in the reporting. And there's multiple reasons, some of them fairly more obvious than others. The providers and the practices, they're skeptic about whether or not there is value in doing the reporting. Sometimes they don't understand what they're reporting, which is more importantly, I think, why they don't see the value. They think that they're just reporting numbers to the government. They don't understand how CMS or the payers are actually using that data in any way, shape, or form. So they think that, in a sense, the government's just throwing more work at them to do. Also, there is resistance to, there's additional cost for hiring consultants, using technology, making sure your EHR is up to date. There's a lot of costs associated when you have to keep up in the realm of quality reporting. And of course, with the cost that comes along with your resource, your timing, your staff. We work with, as an organization, I think more than 40, I want to say 30 or 40% of our providers that report with us every year are solo providers or providers in groups that are 3 providers or less. So you're looking at practices where their wife is the office manager, their wife is the front desk, their wife handles all of their bills, and now the wife also has to deal with the quality reporting. So the wife has got a lot to do, and the doctor still has to carry on with his everyday clinical activities. So when you're looking at the staffing, that's where New Jersey Innovation Institute really comes in, is that our favorite feedback to get from our clients is that you made this so easy for me this year. I didn't have to stress about it. I didn't think about it in my sleep. I knew that I could call you and I can get all my answers and I can just get this reporting done. And of course, there's the overwhelming program requirements. 2,000 pages, 3,000 pages, that's nothing. CMS just loves to write every day. All these acronyms, it's a lot to deal with. So we digest all of the regulations and we break it down into webinars, into one-pagers, into terms that they could understand and relate to. And from all of those barriers that we've noticed in the past 6 years of our successful reporting with our providers, we've definitely learned a lot. And some of those things that we've learned about is clearly articulate the ROI. And what we did at New Jersey is that we built an ROI calculator. So I don't have to talk to you about it. I know everything that I say probably sounds really great, but you may not believe me. But plug in your numbers into our calculator. Plug in how much money you make a year, how many patients you see a year. We will actually do all the calculations for you, and you'll see immediately what your return on investment is once you actually hit a certain quality score perspective. And you want to provide relevant and tailored support. We don't want to just pick up the phone every day and say the same script over and over again. In fact, our team actually rarely has any scripts because of the unique scenarios that our providers are always coming to us with. We're always thinking on the spot, okay, this provider is in this really tricky situation that nobody on the team has ever heard of before. It's a challenge for us, but it's very interesting for us to figure out a way to help resolve that problem for the providers. So it becomes the lessons that we've learned, and then we can incorporate it in our future workflows, our future training. We really get a different perspective from all of these different doctors out there in the New Jersey and across all of the states. And more importantly, align with what they're doing. They're already doing a lot of work on a day-to-day basis. So maybe you say, all right, when you're doing your billing today, you're also gonna check off this box for the quality reporting, just so you don't forget to do it later. Don't create extra work for them, and create as many templates or tools, reminders, whatever you have to do to ensure that they know what to do, when to do it, and how to do it, and do it the right way. And that in turn does reduce the burden of the clinicians, the office staff. Reducing burden makes happier doctors, which makes happier patients, et cetera. And of course, there is another barrier, and that's something that we touched upon briefly, and that's the knowledge and the resources that are available for these doctors. So the programs change every year, but not only do the programs change, but if you're in a larger healthcare system or a multi-specialty group, chances are your provider roster is probably going to change every year too. So with the provider changes coming in and out, you've got different credentialing, different types of Medicare billing charges, different thresholds. How do you handle all of that? We can help you identify which providers are eligible, what they need to report on, and what they need to achieve in order to be successful in their reporting. And basically, the tools that they have offered, CMS has gotten a lot more user-friendly over the past couple of years from their transition from PQRS to MIPS. Their website's a lot more user-friendly. You can actually plug in your MPI to find whether or not you're eligible. But when you've got a group of 150 doctors, you really don't want to be sitting there for who knows how long plugging in the MPIs one after one. We'll do all that work for you. We reduce the burden in that sense. We do an analysis of what your providers have to report on, and we make the recommendations to ensure that your providers are reporting on the measures that really align with their scope of work. And of course, they'll throw in some different benchmarks every year. So I know I was doing well last year, but how well am I going to have to do this year? The benchmarks change every year. Measures don't have benchmarks all of a sudden. New measures are introduced. What does that measure even mean? What do I have to collect? We'll do all of that work for you. We'll help you understand all of that. We'll put it in whatever format you need. We'll do the training for your staff. We really try to make it as painless as possible. So getting to my favorite part of the presentation, and that's because I just work on this grant every day of my life right now, is the Practice Transformation Network grant. So this $50 million grant was awarded to NJII, and what we have to do is we have to ensure that the change package that CMS put together, that TCPI put together, and that's based off of lots of research and case studies that they've done, we have to implement their change package within our network of physicians. So our network of physicians is comprised of pretty much any type of clinician who is any type of specialty. We've got primary care, we've got specialists, we've even got radiologists, anesthesiologists. We have to apply our change package in the way that makes the most sense for these clinicians. So we give them an assessment, we see what their baseline is, how they're doing when they first were enrolled in the program, and then we work with them to achieve the certain milestones within their assessments that they need to move through the phases. So once they move through all the phases, they're able to achieve something called graduation, which means that they're ready to be moved into an alternative payment model. That means that in CMS's eyes, these providers have had the resources, the training that they need to prepare themselves to enter into value-based care. And we are support that will always be there for these providers. We're a grant now, we can always be a resource that they call at the end of the day. Quite honestly, most of our, or not most, but a good amount of our practice transformation clients are clients from the REC program. So we don't lose those customer relationships. We build upon them, and that's actually how we're able to become so successful and work with other programs and other grants because of our loyal clients. So what else we do is we not only educate them on the MIPS program, what their incentive requirements are, but also look at the data that they have within the practice. And I'll show you two really great charts in the next slide. You're looking at the gaps in care. And once you recognize those gaps in care, what do you have to do to close them, to move them, to actually ensure that these gaps in care are going to be closed and driven towards some type of quality improvement? And we use a lot of data to show the providers what they need to do, when they need to do it, and how much they need to do of it. And all of this is done through personalized assistants called coaches. So every practice has one direct contact within NJII. They can always call their coach at any time with any question related to the program, and that coach is going to be focused solely on that one practice to ensure that they follow them throughout the 4 years of their growth. They understand their scenarios, their providers, the way that the workflow is ran in the offices, and they really are ensuring that the practice is set up for success to achieve their graduation. So here you'll see two different charts. The one on the left is a chronic care management chart. So this is one practice that actually worked with us since the beginning of the program, and they did not know how to do any chronic care management services when they first began. So part of our change package is that we teach CCM, and we also teach transitional care management services for these providers. What do you need to do with the patient when the patient is discharged from a hospital? You need to bring them in, you need to do your checkup, you need to ensure that they're following their discharge orders, and you need to make sure that you're doing it really fast, within 7 days after their discharge. Chronic care management is very important. New Jersey has a very sick population, and we're looking at, especially within Newark, lots of comorbidities, multiple chronic care conditions, heart failure, diabetes, hypertension, and how do you control that population to make sure that they don't become more sick? So you can see just from this trend that this provider went from billing 0 to over 600 in just a couple months. And that was really simple for our coaches. It was an intervention that they performed after their initial baseline assessment. They knew that the provider was not doing CCM. They introduced what CCM was. They gave them resources on the interventions that CCM entails. And then they started measuring. They started measuring how many CCMs were given every month. And that's how we're able to show data-driven care, because we have data to show the providers how well they're doing and what progress they've made since the beginning of their time with us. On the right-hand side is something called a run chart. So GPTN has some key performance indicators. Tobacco use is one of them. So we really focus on this measure within our organization and our program. And you can see here the providers, the doctors, they're giving us data on a quarterly basis. We plot the points for them for their performance so they can see their trend. And we also tell them what the baseline goal is. So that's that green line that you see going across. You can see at one point they were above the benchmark, which was really good for them because that was their goal. And then at one point, this was in Q2 of 2017, they dipped really low. And now this is a question for the coach to go back to the practice with. So what happened in that quarter? Did you forget to do your reporting? Did you forget to document? Were your doctors not compliant that quarter? We want to stay consistent. And when you look at charts like this, when you see the data, it drives the questions to ensure that you're following through with the work that you're doing. So that was an example I wanted to give because it shows that a provider may be doing well from Q2 2016 to Q1 2017, but maybe they lose track or they lose focus, and then their data drops, their performance drops. And that is something that the coaches have to keep on top of because they want to ensure that the providers are having steady quality improvement and not random oscillating quality improvement. So the next slide we have does concern the barriers with IT, which New Jersey has a lot of. I'm going to hand this over to Annacler, who is our product manager, so this is her realm of expertise.
Which one is it, the green one?
Yeah, the green one.
Okay, cool. Hey everyone, and thanks Sharlene for the first part of the presentation. So of course, IT is one of the things that really enables the providers to even have data, to even be able to identify how they're performing. It helps us help them identify that, but there are a lot of barriers. as you all know, when the physicians started implementing electronic health records, they were focused on meaningful use money. They were not necessarily considering how well their system would calculate quality measures. Clinical quality measures, even though they were incorporated into the meaningful use program and or as some people know of it as the EHR incentive program. Although they were incorporated, it didn't really matter what the performance was. They could be zero. It was more of a test on how the EHRs would be able to calculate the measures. And so the providers, from what I can tell, they really weren't very focused on how their selection in their electronic health record software would impact them in the future, and how they would get access to their data. Would the quality measures really align with what their practice was and what their specialty is? And so what we're seeing very frequently is that these systems that providers are using, a few of them have pretty good reporting capabilities, but sometimes they're non-existent, sometimes they're very limited, they might not align with the specialty of the provider, and sometimes if they are available, they're very expensive to customize. Some reporting programs require you to be on a certain version of the certified EHR technology, which oftentimes is more money that the providers have to pay out. Even in the practice transformation network that Sharlene was describing, it's our biggest program, and the providers, they run into EHR vendors that will not give them reports that demonstrate their own quality if the provider isn't using if they don't purchase some module. The vendors actually turn off the specific reports, and it's not even like the providers are going to go, take that data and necessarily use another vendor, or that they're not going to use the EHR anymore. They need the EHR, but we see it a lot that providers have to pay for reports that, if I was a provider and I was implementing an electronic health record, I think I would probably take it for granted and just assume that they were going to give me reports on my data. There's varying levels of access to EHR data. We work with one of the largest health systems in New Jersey, and one of the vendors that they utilize does not give them any access to their own data, to their own database. I work with organizations in other states, hospitals in Ohio and Alaska, and other places that have access to their data. It's really common in New Jersey for some reason that the providers have no access to the data. And when you're a large health system, you would hope that your IT staff is able to, generate your own queries, but really the vendor wants you to pay them to do that work. It's really disappointing for a lot of the organizations that we work with, and that adds to their burden, it adds to our burden in trying to help them. And in a lot of cases, our task is to try to work around the vendors and work around the limitations that the providers have with these systems, because there's sometimes no working with them. We try to work with EHR vendors, but they have their own proprietary software. It's their business. They want to make money off of it. But I think one of the biggest things that we've learned is that the vast majority of providers did not have future quality reporting in mind. They were just thinking about meaningful use when they implemented their software, and they couldn't really have possibly known all of the reports they would want to see in the future, all of the quality measures, what the payers would be requiring of them, and what even Medicare's requiring. And you would think that if an EHR is certified, that the provider would be able to, get whatever measures EHRs are supposed to be certified for. But because there's I forget what the minimum is now, but the EHR vendors only have to have a minimum number of quality measures, and it might be quality measures that don't align with that provider at all, that are not the measures that the organization needs to report for their programs. So now, even though the providers have implemented the software, they have to invest in additional technology, oftentimes in complete silo away from their EHR, or they manually collect data and they're not able to align what they're already doing. Like they've already implemented it, they're already using it on a daily basis to record their patient data. Now, a lot of times they have to go somewhere completely different to use NGII's technology, use another registry's technology, or manually collect the data to be able to report on some of the programs. The EHRs also store data in very different ways. So I'm sure you've all heard, like, if you've seen one EHR database or you've seen one CCDA file, you've seen one. Every vendor is really, really different, and I know the people who work with technology and the Health Information Network here are very, very well aware of that. We've seen practices when they switch from one EHR to another EHR have major problems in their quality reporting, where they were able to report on a measure one year and have really great performance, and then the next year when they switched the EHR, something happened in the transition process where with the abstractors who would take the data from one system and put it in the other, didn't put it in the right field, they didn't put it in the structured field, and now the organization has to start from scratch and use their own resources to go back and correct that data. So as I said, a lot of times with EHR technology, we're working around the vendors, we're working around the technology that the providers have access to, and trying to reduce the burden as well as we can. In some of the products that we develop and the services, Sharlene gave you our history, where you could see we started as a registry 6 years ago now, and so as we're advancing, we're always learning brand new things about EHRs. We're surprised by the limitations that the providers face, and what we've been working toward with our multiple tools. So we had a PQRS, which transitioned into a MIPS registry. Then we had a separate system that helped providers report for the GPRO, for the Medicare Shared Savings Program. And then we had a separate system that helped the organizations report for DSRIP, the state Medicaid program that Sharlene mentioned that hospitals participate in. And so we realized that we were doing the same exact thing that we thought was really inefficient, that we could clearly see the providers and hospitals doing incorrectly, where they had separate teams, separate technologies, separate consultants reporting, helping them pull this data out, report on these programs, oftentimes reporting on the same measures in multiple programs, just for like a slightly different population, like reporting on your breast cancer screening for your Medicaid population, and then reporting on your breast cancer screening for all your patients, or Medicare, or United, whatever the program is. And so we realized that we were doing the same thing and being pretty inefficient in the way that we collected our data, because a single hospital or a single large organization that was working with us, they had to log into different tools, and they had to send us data multiple times. And so the product that we've been working on, and I just recently started working on, is, right now we're calling it Measures Manager, and that's exactly what it does. We're using the knowledge that we have gained over the past 6 years from the programs, our relationships with the state, trying to understand what's going to be coming in the next few years so we can be prepared for it, and we can be prepared to assist the physicians with it. The payers, the vendors, trying to really understand what the next step is and what we need to be prepared for. So our Measures Manager tool is really to help the providers prepare for the next phase of value-based care, because for the past 6 years, it's really all been Medicare. I mean, there's DSRIP in New Jersey. We've had hospitals reporting on their Medicaid population, but really, as far as quality reporting goes, our providers in New Jersey have been reporting on PQRS, MIPS, and New Jersey is actually very saturated with accountable care organizations. But they're all Medicare programs, and now that the other payers are finally in New Jersey starting to come out with new programs, brand new programs that are starting, we need to help the organizations scale to be able to, maybe they were able to use manual efforts and get their reporting done for just one program or maybe two programs. But when your reimbursement is impacted not just from one payer, but you have the opportunity to get increases in your reimbursement or avoid penalties in all of the other payers and all of the other patients that you're taking care of, you really need to be able to scale that effort, and they don't want to be doing manual effort. Sharlene mentioned there's a lot of skepticism in New Jersey, and providers are sort of skeptical about even participating in the programs. If they have a choice, a lot of times they would rather just do nothing. So one of our tasks is to make it easy for them and educate them on just how easy it could be and what solutions we have available to them and what they're going to lose if they don't participate. So definitely a key factor is in our development of these new programs are the ability to scale so that the customer doesn't have to be doing something inefficient, so that our team and our technology can effectively scale, automate our processes. That's the biggest thing that our team is working on this year is automating the processes to extract the data, to process the data, and to calculate the quality measures in a way that is not as fragmented as it has been in the past. Managing contracts, like when these providers are managing their when these providers are managing these contracts, it's very new to them. They're familiar with MIPS because it's not all that different from PQRS. It's the same basic concepts, but where there's programs that are going to be assessing the quality of care for your United population or your Horizon population, and then there's risk involved, and there's a lot of decisions to make. And our clients, they can't really make these decisions without understanding where they're currently performing with this specific payer. And the EHR, we have seen mostly they have a limitation on if they do have a breakout of their quality measures, and you can identify what the performance is on those quality measures for a specific population. It's usually just Medicare and everyone else. But that doesn't really help the clinicians understand how they would perform if they entered into a contract with Aetna or with a private payer. So our Measures Manager product, we're hoping becomes like a decision tool for organizations, especially the organizations with large populations and a lot to lose if they don't perform. We want to be able to make them help them make those decisions on whether or not it's a good move to enter into a contract, whether or not they're going to be performing well, what it actually looks like. And to do that, you need more than just the summary level data that comes out of an EHR. We really have to go beyond that. And that was the start. That was groundbreaking when a few years ago when the providers were able to see their performance on each of the measures and see, just a simple numerator and denominator. But it's really not enough if we want to take it to the next level and help them really understand their population and what we call as slicing and dicing their population. Then there's also cost data, which goes beyond just the quality measures, but is looking at the utilization of their patients, not only the services that practice provides, but the services that everyone provides. So every payer really has a different type in their alternative payment model contracts. They have different attribution models where they're assigning accountability of a specific patient population to that group. And it's really the responsibility of that group to manage the entire across the care continuum, whether the patient's going into the hospital, specialists, seeing tests, it's all attributed to that one population. And that's how the providers need to think about this. It's not just about managing their own quality scores anymore. It's about working with other physicians, other physician groups, and managing a patient population for their when they're participating in alternative payment models, which are increasingly risk-based. So our Measures Manager tool, it goes beyond just the summary level statistics. It's really important that the providers are able to see not just a huge organization level report that says how is your 500 provider group performing on a certain measure, but how is each practice performing, how are certain payer populations performing, and are your patients with certain conditions having more costs in certain areas. So it's very important that we're able to present that patient level data back to the practices, but we have to be able to get it first. So there's a lot of those EHR barriers to work through. In the reporting, the providers are really combining the electronic data. We always say, like, we meet the providers where they are. We are not an organization that just says we accept one format, and if you can't meet that, then we can't help you, because that's not really in line with our mission. We're trying to help providers in New Jersey, despite whatever barriers they might have with their electronic health records or with their resources. So we really try to help them manage their performance and optimize their reimbursement, no matter what format they can generate, and then combine that electronic data with the manually entered data into our system. So the Measures Manager tool is really something, it's kind of the culmination of everything that we've been working on for several years. Hopefully by next year we'll have a lot of success to tell you all about. We only have a few clients working on it right now, but for the past year we've already, in the pilot of this product, learned a lot about the different types of technology that everyone is working with. And most importantly is the ability to help the providers manage the patient population despite what technology they have, but also they don't have to keep up with the regulations each year. So Sharlene described the consulting that we have, the support that we give providers to educate them on the changes to the program and what they need to do and who's eligible, and how last year's program is different than this year's program rules. But our technology needs to be able to do the same, and it needs to be able to do the same in a much more efficient way than we have done in the past. So we have a proprietary technology that manages the measures rules, and we have utilized APIs to different data sources to be able to update that on an annual basis, so that we can take some of the guesswork out of it, way reduce the room for error, and completely take that thought process off of the provider's responsibility. So from the I went the wrong way. So from the provider's perspective, from the physician organizations that we're working with, some of the lessons that we've learned is that it's really, really important to have strong, management of these value-based programs and the projects. Be very involved in the project and understand who's doing what, understand who's involved, and which providers are being measured in the program, and that the data availability and EHR support is something that really needs to be key in considerations, making decisions, and when it comes down to the money that it's going to cost the organization to invest in the additional module or the additional support contract with the EHR vendor. I think a lot of times the organizations just don't want to go for that, but if they have very strong management to make the case for investing in that, then they can see these increasing value-based programs that the organization is going to be participating in. In the end, it'll be worth it when they can succeed in all of those programs. And as a vendor, we learned a lot. For one, we completely had to rethink how we looked at the workflow, how we were thinking of it from the program perspective, what they need to do to meet the program rules. But we had to do a lot of work with the few clients who were piloting the product this year to understand how are they actually going to use it, and we really learned a lot from their workarounds. So they would say, yeah, the tool is great, but then we would find out that they were exporting the data and manipulating it in different ways, or making manual reports, things that we could just build in the system that they wouldn't have to do manually, that there wouldn't be room for error and more burden. You know, if they're working with us on this tool, they should be able to use the tool and not have to do extra work on the side. So we learned a lot about the workflow and what these organizations are really doing on a day-to-day basis, what they want to see, and what actions they need to take from that. Being flexible with data sources is very, very imperative. I cannot imagine being one of the vendors who just takes one data format and doesn't work with you if you can't produce it, because I don't know how you would stay in business. But we take pretty much any format. Of course, there's a preferred format that we would like to accept, and it would be wonderful if everyone could provide that. But we really work with whatever data the EHR can produce or the IT staff within the client can produce. And we definitely learned that we should never underestimate how long the discovery process was going to take, because the different EHRs vary so much that some vendors, they don't give us any, not only there's no access to the database, but there's no support to help us figure out what is what. In some cases, we're just getting a ton of zip files or just like a data dump where we have to sort through and there's no data dictionary, and it's really difficult. It's a lot of, it does put more of the responsibility on the providers and their quality teams that we're working with when we have to continuously validate, because we don't want to run the risk of reporting data inaccurately or misinterpreting something. So we have to continuously validate and say, is this, go check and make sure that we're interpreting this correctly. Did this patient actually have this certain performance? Because we definitely want to fulfill the need of being accurate and meeting the provider's needs. And sometimes it can take a long time. So what's next for our organization is really putting more processes, like refining the Measures Manager product, as well as our services, working hard to understand what the providers really need to succeed and to expand across whatever programs New Jersey comes up with to manage the performance on the payer side. So we're in touch with pretty much every payer in New Jersey. We really want them to keep us in the loop with what's next, and then we'll be able to meet the needs of the providers the best way that we can. And then, as Sharlene mentioned, we are creating a clinically integrated network because as these providers graduate from our program, which means they understand their quality, they understand how to improve their quality, they're mature enough to be able to look at the data, make improvements, and really manage their population, they need to graduate into an alternative payment model, because that's really the next phase of where all the providers are going. So if there's not an ACO, an accountable care organization that really fits, if they're in a specialty that there's no other option for, then we want them to work with us, and we're building a clinically integrated network to then use our own tools and do the same thing that a lot of the other ACOs and clinically integrated networks are doing, and be able to use all the lessons that we've learned to help the physicians who really want to participate in alternative payment models but don't really have many options. And next, the New Jersey Health Information Network. Neither Sharlene or I work on the MiHIN team, but we got some updates to provide, and I think some of you may have heard one of our colleagues earlier this week. So as far as the MiHIN is concerned, we're currently onboarding 9 trusted data sharing organizations onto the MiHIN use cases. We've hired a huge team that is working with the organizations that are onboarding onto the system. So of course, with new technology, it's critical that you have the support involved. We're creating opioid-related use cases to test the system, and facilitating funding opportunities to continue to grow the interoperability in New Jersey, since it's really, we're developing it for the very first time. So we're excited to be able to marry all of this different information together, give the doctors in New Jersey a lot more information than they've ever had, and hopefully be able to continue to improve our readmission rates and sort of get out of the really poor ratings that New Jersey has right now in healthcare. Any questions?
Thank you. So, thank you. In the very beginning, you talked about going out and teaching some of the chronic care management to the offices. So, is that I'm just curious, in general, I mean, is the value add actually teaching? I mean, I've worked with a lot of physicians' offices before, and I think they know what to do, right? They know what good quality care looks like. It's more about what resources do they have available, you know, what sort of support do they have in being able to even access process metrics. So how much of it is doing that, and how much of it is actually teaching them the content? I don't know if that makes sense.
Yeah, it definitely makes sense. And I think from what I've seen, the offices, they understand the concepts, they understand what they need to do to really care for their patients, but they have to meet certain program requirements. So they have to do certain things and check off certain boxes to be able to benefit from the chronic care management payments from CMS. And so it's sort of hand-holding and educating about the program, educating how to best use their technology tools or find the tools that will help them facilitate that communication with the patients, to be able to get that data from the hospitals, to understand like who's, for TCM, I mean, to understand who's being admitted to the hospitals, readmitted. I think there's a lot of education that needs to happen related to what tools to use and what resources to use to facilitate it.
And something that we do within the network is not only do we teach about the clinical services that the doctors should be practicing, but also we help create those internal staff workflows. So it's specific to each of the practices, obviously, but the coach would actually look at the practice workflow or the practice staffing and the resources available, and they would say, okay, maybe Nurse Jackie starts off with this. She does this, this, and this, and then she alerts the doctor this before the doctor comes in to start doing this to prep the doctor beforehand. So it's a little bit of internal workflow, the resourcing, the education, and definitely facilitating the data sharing.
Sharlene, you mentioned coaches in your practice transformation network. I have a question about that. How many provider practices are in your practice transformation network, and how many coaches do you have to provide that kind of individualized and targeted support to the providers?
That's a really great question. So I'll just hone in on New Jersey itself. We have around 4,000 enrolled clinicians, and our largest group of clinicians is 500 providers. So we look at it on a provider basis rather than a practice basis. So a coach can be assigned anywhere from, I want to say like 45 to 60 practices, 60 being the most. And the coach that has the practice that has 500 providers, that's one practice. So she'll more likely have like less practices that she handles because she has more providers to cover. We're not very strict about you have to have this credentialing, this certification. We are looking for people who have a clinical background, people who have quality improvement processing backgrounds, and just anybody who's had a wealth of experience and exposure in the healthcare industry.
Yeah, well, when we started out with the grant, when we originally wrote the proposal, we said everyone is going to be an RN, and every coach is going to have those credentials. But over time, we found that it wasn't really feasible to do that, and there were also so many other areas that can help the practice, like the more of an IT background or extensive work in a practice setting, doing that management of all the different areas.
Thank you.